Hi, my name is Sarah Zunian Sadhu from the University of Texas Health Science Center at Houston, Cizik School of Nursing, Master of Science and Nursing in the Family Nurse Practitioner track for 2023. Today I'm sharing with you the diagnostic tests and procedures for bronchoalveolar lavage. What is a bronchoalveolar lavage? A bronchoalveolar lavage, or BAL, is a minimally invasive process where sterile normal saline is introduced into the lungs and suctioned out under controlled conditions. You may be wondering how fluid can be introduced into the lungs without drowning a person or causing them harm. Well, let's find out. The first time I heard of a bronchoalveolar lavage was in the emergency department. Our team had just stabilized a patient who was in a life-threatening cardiac arrhythmia. He had aspirated his own vomit while at home and collapsed. Much of the aspirated material was suctioned out, but his lungs still sounded coarse and wet. After he was intubated, our ICU nurse practitioner mentioned that she would perform a bronchoalveolar lavage to remove the remaining aspirated food in his distal lungs. Without this procedure, he would risk chemical and aspiration pneumonia. Both are life-threatening. Why are bronchoalveolar lavages performed? Well, to save a life, but for more than that. A ball is used for several reasons. It is used as a diagnostic tool, as a therapeutic tool, and in research. The first bronchoalveolar lavage was performed in 1927 using a hard and inflexible bronchoscope. Since that time, it has advanced significantly. It is considered minimally invasive and safe. It is commonly used as an outpatient procedure. It is also paired with other important procedures. The flexible bronchoscope has a light and camera that allows a practitioner to see the lung as fluid is infiltrated and suctioned from the lung. The camera also allows a practitioner to guide the bronchoscope and pair it with other procedures. As a diagnostic tool, the ball is used to analyze cell counts and differentials, cytopathologic analysis, cultures to specific molecular and immunologic diagnostic tests, to diagnose lung infections by collecting qualitative bacterial cultures and differentiating cell types, testing for malignancies, taking cell samples to determine bronchoalveolar carcinoma, confirmation of interstitial lung disease, and testing for alveolar hemorrhage. Analyzing bowel fluid helps in the diagnosis of various lung disorders, including lung infections such as tuberculosis, bacterial pneumonia, fungal infections, and lung cancer. Bacterial alveolar lavages are also used to support the diagnosis of pulmonary sarcoidosis or hypersensitivity pneumonia, acute alveolar opacifications on chest imaging, presence of significant bowel eosinophils to indicate eosinophilic pneumonia, diffuse alveolar hemorrhage, and eosinophilic lung disease, chronic obstructive pulmonary disease, and asthma. What are some of the signs and symptoms that a person needs a ball? Persistent cough of an unidentified origin, trouble breathing, coughing up blood, immune system disorders, cyanosis, and HIV and AIDS. In one case, a 31-year-old female found herself perpetually out of breath and suffering from fatigue. Simple things like going to the bathroom or getting up from the couch were exhausting her. She began to lose weight. After about a year of attempting normal activities, she became cyanotic. Her lips were blue. When she visited her physician, she found that her oxygen saturation was in the 60s. She was immediately admitted to the hospital where blood clots and pulmonary embolisms were ruled out. X-ray revealed a leopard print of black and white patches on her lungs. Through testing, her pulmonologist identified her condition as pulmonary alveolar proteinosis, or PAP. PAP is a rare condition where surfactant, which normally helps the alveoli to stay open, builds up. The lungs become gunked up with surfactant, making it hard for oxygen to pass through the alveoli to the blood. Not only can a bowel help to diagnose PAP, it can help treat it. How is bronchoalveolar lavage used as a treatment? I've included some websites where you can actually watch Watch a mini bowel and a whole lung lavage. They're fascinating. A ball is used to flush aspirated material from the lungs. Flush the lungs in a whole lung lavage, as was done for the woman with pulmonary alveolar proteinosis. Bronchoalveolar lavage is used to treat burn patients who are not able to expectorate mucus or mucus plugs. Ball treatment is used as a wash using small aliquots of sterile saline to help dislodge distal mucus plugs. This is most beneficial to those with an endotracheal tube or tracheostomy who are too debilitated to be able to expectorate by themselves. For exogenous lipoid pneumonia from milk aspiration, for kerosene aspiration, in children with refractory mycoplasma pneumonia complicated by atelectases. In the case of our 31-year-old female with PAP, she underwent a whole lung lavage to remove the buildup of surfactant in her lungs. As much as 4 liters of fluid may be flushed through each lung, and they may do this procedure where they flush one lung one week and then they'll flush the other lung the following week. Bronchoalveolar lavage is also used for research purposes. Most notably, Ball is used to understand the biology of alveolar macrophages and CD4 positive T cells. Their contribution to the HIV reservoir could lead to important insights into the challenges of an HIV cure. The isolation of primary macrophages from bowel can be applied to various other research areas, including inflammatory or infectious pulmonary diseases such as asthma and tuberculosis. How is a ball performed? A mini ball can be performed with the patient under conscious sedation, while the patient is seated in a reclined position similar to a dentist chair. A general ball is conducted under sedation while the patient is intubated. Prior to the ball, the patient is pre-oxygenated, an IV is placed and sedation prepared and administered. Lidocaine is introduced into the airway to reduce irritation and involuntary responses while the procedure is done. The patient is intubated but may not be with a mini ball. The bronchoscope is guided as far as possible into the tertiary or targeted airways. Avoid suction while advancing the bronchoscope. 2% lidocaine is directed at bifurcations to reduce airway irritation. Apply low suction wall pressure when the bronchoscope is wedged in the tertiary airway. While applying brief gentle wall suction, check for airway collapse. If the airway remains collapsed after suction is stopped, the bronchoscope is wedged too deeply in the airway and needs to be retracted slightly. Infuse 20 to 30 milliliter aliquots of sterile normal saline using a 50 milliliter syringe, and watch for airway blanching while infusing the sterile normal saline. This is expected and a positive sign. After instilling the fluid, gently suction out the fluid and expect a minimum of 30% of fluid return. If you do not receive at least 30% return of the fluid with suction, stop the procedure. For diagnostic tests, 300 milliliters is generally instilled. Of the 300 milliliters instilled, only 20 milliliters will be used for testing and diagnostic purposes. A whole lung lavage or wash will be performed while the patient is sedated and intubated with a double lumen endotracheal tube and bronchoscope. One whole lung, either the right or left lung, will remain intubated with air ventilation while the other lung is flushed or washed. The equipment needed to perform a ball is a sterile saline lavage, specimen container with trap that is labeled, topical lidocaine, gel lubricant, scope and suction tubing, endotracheal tube, sedation, medication, dressing pack, blunt tip needle, 2 50 milliliter syringes, and a 100 milliliter of sterile normal saline for a mini ball, and up to 4 liters of normal sterile saline for a whole lung wash. Prior to the procedure, wash your hands and don sterile gloves. Collecting equipment should be laid out and maintain a sterile field, even though this is considered a clean procedure. The procedure is contraindicated for patients that are hemodynamically unstable, have traumatic brain injury, are unable to tolerate or risk an increase in intracranial pressure, have severe life-threatening respiratory failure, are dependent on high PEEP settings, and have worsening hypoxemia. This procedure is performed by a pulmonologist, a trained pulmonary nurse practitioner, or medical doctor, though it is most commonly performed by a pulmonologist. I hope you've enjoyed this presentation. I've included billing and coding guides, which can be found at the website noted on this slide. And we'll quickly go through some of these billing codes. You can pause and take your time looking over them. It does require a lot of training. They've found that training of 10 years gives the best results for a patient outcome. But this is something that an advanced nurse practitioner is very capable of doing. Thank you so much for